All right. Hi, folks. Thank you all for being here today to learn about this important topic of elder justice. It's my extreme pleasure and honor to be able to introduce our plenary speaker here today. Dr. Anne Fabiny is the Associate Chief of Staff for Geriatrics at San Francisco VA Healthcare and Professor of Medicine at the University of California, San Francisco. We thank you all for being here. During the course of Dr. Fabiny's presentation, please feel free to drop any questions that you have into the chat or the Q&A, preferably the chat if possible. I will be monitoring that and will present your questions aloud to Dr. Fabiny as time permits. So without further ado, I know I'm not the one you all are here to listen to today. I'm going to turn it over to Dr. Fabiny. Thank you for being here with us, Doctor.
Oh, golly. Good afternoon, everybody. It's morning in California, but afternoon in Florida. And I am really delighted to be here with you. It's a great opportunity for me as a physician to talk to legal colleagues about this partnership that we have here at the San Francisco VA healthcare system, where our lawyer, who represents the Medical Legal Partnership for Seniors, comes here on site, and we really collaborate in a very interdisciplinary way to improve the lives of the older veterans who we care for here. So this is an example of how a medical legal partnership for seniors can look. And I'm eager to answer your questions as I go, so please do put them into the chat. I'm happy to stop and start. I enjoy talking about this when people can ask their questions as issues come up, so it's not an interruption. The learning objectives for this talk are to describe what a medical legal partnership is and how it functions. I'm going to give you some examples of how those medical legal partnerships can address social determinants of health using a particular model that I help run. And then talk about models of integration of medical legal partnerships into a specific healthcare system, in this case, the San Francisco healthcare system. And I will just, I'll finish by describing the outline. So I'm going to use two cases as starting points for the discussion, then talk about what an MLP is, are they effective, and then, as I said, I've described to you the model that we have here. And before I start, I will give testimony about how my practice of medicine. I'm a geriatrician. I only take care of older adults. My practice has really changed since learning from Sarah, the lawyer who comes here to work with us, has taught me and taught all of us how to better identify older adults' legal problems. And one thing that I realized as we're developing our collaboration is that physicians are really the only professional that most older adults can see without having to pay that professional's full fee. And here at the VA, most of the older veterans don't even have a copay for their visit, so they can come and see a doctor for free. And that means then that they bring all sorts of problems to the doctor's office, not because they don't know any better, but because, especially when it comes to legal problems, as most of you know, since you're in the legal profession, legal literacy is low. And I count myself among those who have poor legal literacy. And so older adults will bring problems to the doctor's office that they themselves don't understand to be legal problems because their legal literacy is low. Then they bring them to a doctor or a nurse practitioner or a nurse or even a social worker whose own legal literacy is low. And so there's this stew of people meaning well and wanting to help, but not really being able to find a way forward. And I and my colleagues geriatricians and non-geriatricians, doctors, social workers, nurses, we all really struggled as healthcare providers to try and solve problems that were in fact legal problems. And of course, we were frustrated and ineffective because we're healthcare professionals, we're not lawyers. And so once we were able to better understand what those legal problems look like, how to identify them in a medical clinical setting, and then articulate them to a lawyer who could actually help, it really opened up a brand new world of collaboration and sense of effectiveness and ability to help our patients. So an example of one of those patients is Mr. Smith here, 71-year-old man, divorced. For those of you who work in a VA setting, you might understand the service connection. So that means that his medical problems are connected to his service in the military. He lives in the community, and he came to a scheduled primary care visit with his ex-wife, who checks in on him periodically. She reports concern about increasing forgetfulness and home safety with frequent falls. She also says the patient's landlord has told him she can't allow shower bars or other hardware to improve his veteran safety for the landlord. So his past medical history is, from the perspective of this conversation, significant for his cognitive impairment. He's able to dress himself, bathe himself, feed himself, get on and off the toilet, and out of bed, but he does need help with managing his finances, managing his medications. His ex-wife helps him grocery shop. That abbreviation there, IATL, means instrumental activity. So that's transportation, shopping, managing medications, transportation. So he needs help with those more complex tasks. And he's fallen 4 times in the last 6 months. Nobody really knows why. He lives alone. He gets Meals on Wheels. His ex-wife visits him weekly. He has a few hours a week of a home health aide, but doesn't really have much of a social network. So his ex-wife is really his primary support. And that is a very typical presentation for the older veterans who are cared for here. And probably it's true for some older folks who are young as well. So the clinician does her thing, and I've moved well in the medical part for the purposes of this talk, but the clinician sends or puts in a consult so that the veteran can have his own memory clinic. And then she talks with the team social worker about the patient. And the social worker says, do you think we should also contact our medical legal partner? So the question is then, how would one as a clinician describe the concerns that the clinicians have about this veteran? How would they describe them to you? Well, probably that as well as I do now, better. So medical legal partnership model is a health care delivery model that improves the health and well-being of low-income and vulnerable populations by addressing unmet legal needs and removing legal barriers that impede health. It's really true integration rather than just referral, and a process of interprofessional training, back and forth communication, and so one of the extraordinary things about, at least to me as a doctor, after practicing for so many years in a healthcare setting, a lawyer present, is that Sarah, our attorney, came to the clinic, and in the clinic area where we all have our exam rooms, she had an exam room. And she obviously wasn't doing medical exams, but she was sitting there awaiting what we call a warm handoff, so that as we identified unmet legal needs of our patients, we could actually say to the veteran, and there's a lawyer here who I can introduce you to, and you can make an appointment with her, and she'll be able to help you with these things that I can't. And that warm handoff, we have to do just as a way of making it clear to the veteran that, first of all, this lawyer is actually accessible, that she's right here and can talk to him for a few minutes now, establish the best place to have the visit. So another great thing about Sarah's involvement with us is that she also made home visits. So she could see the veteran back in the clinic. She could actually make an appointment to his home. She also took referrals in our nursing home. And so would go see the veterans in their rooms in the nursing home. And also takes referrals from the inpatient acute care hospital. Takes referrals from the teams that can. So she will go to the veterans hospital room in the hospital and set up an appointment or deal with things in the hospital. That's what the situation requires. So, and by being on site in all those different clinical venues, Sarah also knows the social workers, she knows the nurses, she knows the doctors and the practitioners, and she's able to develop a network of colleagues. We develop it with her. So this, and she's done formal trainings and informal trainings for the social workers and nurses and doctors, and it's really been doing this since 2015. So it's almost a 7-year relationship at this point. And, it's this now very rich, very highly interconnected that we have that supports our veterans. Alexis.
Yes, Dr. Fabiny. I know we're having some folks that are having some trouble hearing you. I'm not sure if it's the volume of the microphone. Is there any way that we can either increase the volume of your microphone? Very sorry for that. Just so everybody knows, Dr. Fabiny is in here joining us from California. So we're across the country. So if we can find a way, that would be great.
Yeah, well, I just put the microphone all the way up to 100. Does that help?
It sounds good to me. I'll keep monitoring the chat and see what folks say, and I will let you know.
All right, good. Well, and I can also, I'll speak as loudly. Right. Well, I'm really sorry for those of you who weren't able to hear everything. So the challenge that this partnership is working to overcome is that older adults are living longer, and many of them have complex medical issues and comparatively fewer financial resources and social supports. There are multiple legal determinants of health, as all of you likely know. So legal planning for incapacity, access to safe housing in the community, that's a particular problem here in San Francisco, access to community-based and institutional long-term care, and access to healthcare and financial supports. And so the opportunity that we have to overcome those challenges is when we work together, because as I described, the medical team is often the first group of professionals who see the patients with these problems. But of course, we don't have access to the legal solutions, and then lawyers can obviously help with those legal solutions. But because of the frail population who we take care of, as I alluded to earlier, frail older adults and isolated older adults are the least likely to seek out or have access to legal assistance. And so that's why this partnership is so effective, because it provides lawyers and the legal system access to people who otherwise probably would not have the wherewithal, either financial or cognitive, to make their way to a lawyer. And then certainly for the patient population that we care for, there's no way except for using a legal aid office that these veterans could afford to pay a lawyer. And for those of you who aren't familiar with this concept of social determinants of health, they are the social and economic conditions in which people are born, grow, live, work, and age that influence an individual or a population's health. And this is a complex slide. Oops, another slide. Alexis, looks like the slides are not,
Are they not moving over?
well, they are on my screen, but with,
So right now it says medical legal partnership model over here. Okay, and now it just moved over and it says the problem and the opportunity. Now it says social determinants of health at the top.
super, that's the one I just, okay.
Fantastic.
There.
Inequities and social political determinants of health.
Yeah, so this is a complicated slide, and I'm putting it up not to read through it, but just to illustrate the point that there are different kinds of effects or pressures or influences on any one individual's health. And doctors and healthcare systems are usually on the right-hand edge of the screen. So we deal with individuals' risk behaviors and disease and injury. Then in the middle, where doctors and healthcare systems have less agency, are the living conditions that patients have in their lives. Although healthcare systems are working hard to move into that physical and social environment for very vulnerable populations. And then on the left are those larger cultural, social influences, things that people are born with. So their race, ethnicity, their immigration status, gender, sexual orientation, the class of the family they're born into, and then large institutional inequities too that have an influence on living conditions that then individual person's health. So that's sort of the sketch of what we're talking about when we talk about social determinants of health. And fortunately, medical legal partnerships in the US are fairly common. And as this slide demonstrates, there are 138 in general hospitals and health systems, 37 in children's hospitals, and the very first medical legal partnership started in a pediatric clinic. There are 163 HRSA-funded health centers that have them. So that's Health Services, Health Research and Services Administration, that's HRSA, part of the Department of Health and Human Services. 83 other healthcare sites and 29 Veterans Affairs medical centers. This is a slide of where they exist across the country, and Florida, fortunately, is dark blue, which means there are more than 10 medical legal partnerships in Florida, which is fabulous. And these medical legal partnerships take various forms. There's a general population model where legal services are available to a healthcare organization's general patient population. And then the kind that we have here in San Francisco, which is targeted to a very specific population. And those specific, ours is older veterans, but obviously there are all sorts of special populations that provide these services to. Well, great. Do they work? Certainly my own personal experience is yes, and fortunately there's data to support that. So it does show that the collaboration does help to resolve legal issues. So improved access to retroactive benefits and debt relief. Patients who have access to the service are more likely to have utility shutoffs. Health incomes that come to people who are beneficiaries of this sort of collaboration show a reduction in stress, improvement in asthma control, better use of preventive care for newborns and infants, decrease in readmission rates, that's readmission to a hospital, inpatient hospital stays, and emergency room visits. And then for those of us on the healthcare side, it relieves a lot of moral distress that teams often feel when there's clearly a problem and you don't know how to resolve it. So there's that decrease in moral distress, and also improved comfort in discussing unmet social needs when there's a resource available to help address those needs. So that's the moral distress part. It makes it easier to practice medicine knowing that one has all the tools in one's toolbox that the patient needs to use. And this was a paper that was published in 2017, looking specifically at medical legal partnerships at VA medical centers. And the partnership served 900 veterans in New York and Connecticut, examined legal issues, services provided, the time spent that the lawyers spent with clients. And after a year, there were significant reductions in symptoms of hostility, paranoia, and anxiety. GAD is general anxiety disorder. There were improvements in housing status and total income, mostly from VA disability compensation, and significant improvement in general health and mental health subscales. So that's 5-year-old evidence, but recent enough that we regularly cite this paper when we're making revisions. And this I-HELP model is a way to remember the different areas in which medical legal partnership can actually help an individual or population. So the I stands for income, supports, and insurance. H is housing and utilities. E is education and employment. L is legal status, and P is personal and family stability. And you can see in the boxes what sort of specific actions can be taken by the legal team to address those needs. With veterans, for those of you who work with veteran populations, discrimination that veterans were on the receiving end of when they were in the military often gets in the way of their receiving appropriate benefits. And so a lawyer can really help a veteran get access to those benefits that they've been denied on the basis of discrimination. They also help identify and report trauma during military service, and veterans get more services and supports when they can demonstrate that they have been trauma of any kind while in the military. And then, as many of you I'm sure know, the GI Bill was not the resources made available to veterans through the GI Bill were not distributed, and Black veterans did not have access to those resources. And so for older veterans, having access to the resources of the GI Bill. So here's Mr. Smith again. So he lives alone. He's got an ex-wife who's really his only caregiver. He's got memory problems. He's been falling, and he really needs shower bars and other hardware installs in his apartment to improve his safety. And his landlord has said, well, she can't do that. And if he keeps falling, she's going to have to. So the Medical Legal Partnership for Seniors legal team met with Mr. Smith, conducted an in-depth legal checkup, and provided legal services to help improve the situation. And so the lawyer drafted a reasonable modification letter and worked with Mr. Smith's primary care provider on the accompanying physician letter. And that's one thing that Sarah has really taught all of us, is how to write a good letter as the supporting doctor when advocating for a patient. So the letters went in to the landlord to request shower bars and safety hardware. And then, knowing that there was a lawyer on the team, the landlord agreed to the safety modifications because, of course, in California, she's required to do that. The lawyer counseled Mr. Smith on his housing rights because he was worried about the eviction threats. And that's really something here in San Francisco that older adults live under, and that is the threat of eviction. And so many older veterans live in rent-controlled apartments, and there's really a fear of being tossed out as the landlord decides that he or she wants to do something different with the The lawyer drafted Mr. Smith's durable power of attorney for finances and a simple will. So you can see that the legal work, certainly in this case, was not complicated or wildly time consuming, but made a dramatic difference in Mr. Smith's health and well-being and his ability to live in the community. So of that IHELP acronym, obviously access to safe housing was one of the areas that Sarah focused on, and then personal and family stability by getting the durable power of attorney, finances, and in this case, she also got the durable power of attorney. Another place where we see with the medical center legal problems manifesting themselves is when adults are in the hospital and we're talking with them about where they're going to go. It's time to leave the hospital. So Ms. Powers is an example of the challenges that we face oftentimes in the hospital. So she's a 79-year-old unmarried female veteran who was brought to the emergency department and admitted 2 days ago after being found in a disheveled state by a neighbor. She's had multiple emergency department visits over the past year. Neither the emergency department assessments or subsequent assessments since her admission to the hospital have revealed any acute medical process. So there's no new or pressing medical problem that she needs to be in the hospital for. However, there's concern for significant worsening of her previously cognitive impairment. And I cannot tell you how often this happens. A nurse practitioner whom I worked many years ago described it as a person driven off the court. So you can all, if you can see this person in their natural environment, you can tell that things aren't going well, but it's hard to know what to do. Safety is a huge concern. Her neighbor reports that she leaves the stove on, regularly falls, can't get up, so the neighbor's really been paying more attention to her and trying to help her out, but she's just the neighbor. The inpatient medical team did an assessment of the cognitive function with this test called MLPs, and she scored 16 out of 30, which is very impaired. So she likely that she does have dementia. And unlike Mr. Smith, who is living in the community, Ms. Powers needs help with bathing and dressing, so she really is and she needs help with transportation, grocery shopping, for medications, managing finances, even using the phone. Her neighbor, who's really her primary contact, says that Ms. Powers has no known friends or family. Maybe there's a cousin in Los Angeles. She lives in an apartment downtown, and she's been retired for 14 years. So the medical team, when they're visiting Ms. Powers in her room, a member of the medical team says, "Sounds like she can't go back to her prior place safely. Do you think she needs conservatorship?" And this was a question and a path that we used so frequently up until we started this collaboration partnership for seniors. And we, the healthcare teams, had this very misinformed idea of the power of conservatorship. Really changed our practice in the hospital and the clinic as a result of having learned both from Sarah, our lawyer, in the medical legal partnership for seniors, and actually meeting with what in California is called the public guardian's office. And I'm sorry that I don't know the equivalent in Florida, but developing a relationship with public guardian's office and the medical center has really served both entities well. They understand us better and we understand them. So as you all know, laws are state specific. So there's guardianship of the person and guardianship of the state. There's more permanent guardianship and temporary guardianship. And the question that we always got the answer to wrong until Sarah educated us in the public guardian's office is, will conservatorship solve the problem? And to parse that out and better understand what it is people are really trying to accomplish. Is it a decision-making problem that's really the issue with this patient, or is it a resource problem? And as you all know, conservatorship, which is what it's called in California, transfers decision-making authority from the patient to another person. But the big aha moment that we had in the medical center is that it does not generate underlying resources that the individual or the community doesn't already have. So it doesn't matter who's making the decision. If there's no nursing home bed, there's no nursing home bed. And if there's no appropriate housing, it doesn't matter who's deciding where the person's living. There's no good housing or access to home health aides or income. And we were under this very misguided notion that a conservator or guardian would have access to resources. And of course, that's not the case. And really, our goal is to find the least restrictive alternatives to probate conservatorship. So our medical legal partnership for seniors at the VA serves as a patient advocate to prevent and avoid the need for conservatorship. And our MLPs does not help to conserve patients. And that's the reason that one of the reasons that's true is because currently the city and county of San Francisco are supporting Sarah's work. And one of their goals in supporting this advocacy is to unburden the court with requests for conservatorship because very often, because, you know, as was the case with us, these requests to the court are really misinformed, not adequately understood. So the city and the county are really working with the court system to unburden the court and really only make those cases that come forward to the court those that need to be addressed by the judge. And so we have dramatically decreased the number of applications to the court for conservatorship or guardianship since we started working with them. And so, as you all likely know, lesser restrictive alternatives can prevent the need for conservatorship. So there are patient-reported surrogates, there are other financial surrogates, and the VA in particular has VA fiduciaries, and we are using VA fiduciaries much more frequently now. There are health insurance benefits and other veteran-specific benefits that our patients can have access to, and Sarah works to figure out what our veterans are eligible for. There's something called a long-term care waiver or assisted living waiver here in the state. And there are income benefits, veterans in particular, that veterans are eligible for to stay in the community or find a lesser restricted living setting. It's called a boarding care. So here's Mr. Powers, or Ms. Powers rather. So she's in the hospital. She doesn't really have a medical problem. She's got a living problem. She's not safe in her apartment anymore. And like certainly it's the case in VA hospitals around the country, have veterans who wind up staying with us for months and months and months, and sometimes, I'm sorry to report, years, because there's literally no place for these veterans to go. And so that's happening much less frequently now that people consider. We certainly do still have veterans who have trouble moving out of the hospital. Need to change the veterans go to the hospital when they don't need hospital care. So the team met with Ms. Powers and did a legal checkup and completed a capacity assessment. So Sarah does a financial capacity assessment, not a cognitive capacity assessment, and it's different and really critical in cases like this. So Ms. Powers did have enough capacity to complete a durable power of attorney for finances. And she did so, and she named someone she trusted to manage her bills and other finances. The lawyer counseled Ms. Powers and her agent on Medicaid asset and spend down laws. And that's something that Sarah does a lot of, is teaching veterans and their families about applying for Medicaid and spend downs. And Sarah also helped Ms. Powers and her agent apply for Medicaid. She was approved for long-term care and was eligible for the long-term care waiver to help pay for a boarding care, which is a term for assisted living. So working with a lawyer, there was, and without applying for conservatorship, there was a way forward that allowed Ms. Powers to live in a least restrictive environment, her autonomy to do what she was able to do so. So for Ms. Powers, Sarah helped her with income and insurance and personal income and stability. So again, this is a slide you've seen already. Just want to emphasize that this collaboration that we have is really true integration rather than just referral. So certainly circumstances determine whether real integration is possible versus a referral, but it can really testify to the power of having a on the campus of the medical center, developing relationships with all the variety of clinicians and being able to meet again, in our case, the veterans, in the moment when those legal needs are identified and are really most pressing and are having, in some cases, really person's health need. We've had different sources of financial support. So at the start, so the medical legal partnership started in 2012 with University of California School of Medicine. It came to the VA in 2015. So the UC Hastings Law School Clinic funded the effort at the beginning. And then starting in 2015, we had an Equal Justice Works Fellowship. And when that fellowship ended and couldn't be renewed, we applied for funding from the city and county of San Francisco, and we're delighted to award a grant that has provided us with funding since then, and will continue to. And this is a sketch of what I have been discussing with you. When Sarah first got here, she provided training to nurses, social workers, doctors, nurse practitioners to recognize these legal needs and refer patients to MLPs. So I actually changed how or the questions that I asked patients and things that hadn't occurred to me to ask. I started asking about it. Sarah gave us a list, a cheat sheet of things that we could ask that would facilitate our understanding that there was actually a legal problem here and that referral was appropriate, because it doesn't do any good to have a lawyer sitting in an exam room down the hall if the doctors and the nurse practitioners and the social workers and the nurses think, oh, we don't need a lawyer. So she really committed a significant amount of time doing formal trainings and informal trainings and sitting next to us at our desks and talking things through. It was really a dynamic interactions that Sarah does. And then obviously that teaching and training resulted in referrals. And then Sarah, as I described, met with veterans in their homes, in the clinic, in the nursing home, in the hospital. Sometimes patients would come to the clinic at the law school, but that was, I think, the least frequent site of interactions. And then Sarah Sarah would do capacity planning, simple estate planning, eviction prevention, review the income benefits and make sure that the veteran was getting all the income that he or she was eligible for, insurance benefits. She's really helped end elder abuse for some of our veterans, and also the sort of consumer harassment and abuse that can come through phones, mostly phones. So Sarah's really done a lot of teaching, helping older veterans identify scamming calls. And then we have a weekly meeting to discuss complex patients, and Sarah, the lawyer, attends that meeting every week. And to have, so these are, it's a referral committee that receives referrals about the most complicated patients in the healthcare system. And so we've all continued to learn with and from Sarah as she engages in these conversations with this referral team to help solve complex problems. And this slide has links, and these slides will be available to all of you, and so to them will be links. So to have a medical legal partnership out of VA, you're required to follow certain steps of Directive 1510, and there's the link to the directive so that you can understand what's required. And then there are enormous resources if you're thinking about a medical legal partnership period. I think the place to start is the last bullet under that technical resources for starting MLPs, and that is the National Center for Medical Legal Partnerships. That organization is committed to helping establish new ones, and so they're incredibly enthusiastic and supportive, and there's piles of information on that website about how to get started. And there are funding resources to start medical legal partnerships. The VA is working on regulations because Congress has approved appropriations for the VA being able to pay lawyers to represent veterans. And then there's some other potential resources listed here. We've had success with that, as I told you already. So I hope that you now have a better understanding of what a medical legal partnership can look like. Again, this is just a model, it's not the model, and how we function. You've been able to see how that partnership can support veterans, both who are out still living in the community and those who are in the hospital. I've told you a little bit about how our referral system works. And one thing I didn't tell you about is that there is an actual electronic referral document that any referring provider fills out and sends to Sarah electronically. And here at the VA, if we're going to refer a veteran to Sarah, we need to get the veteran's explicit consent. And so there's a consent form that the veteran has to fill out, and then these are the resources and the references. Again, those will be available to you at your how, but Alexis will take care of that for sure. And that is the end. And be delighted to answer any questions or respond.
Yeah, thank you so much, Dr. Fabiny. I know we had some trouble with quality of the audio. I'm hoping that was resolved for most people, but I do want to reiterate that this recording will be available at a later date. Additionally, the PowerPoint, all of the resources are also available for you to look back on. There were no questions in the chat, but I had some questions that I wanted to present. First, I wanted to thank you for really reminding us of the importance of the relationship between our legal professionals and medical professionals. It's sort of, you know, that communication and the way that it can target and really strategically get the best result for our clients is really invaluable. And I think that you really express that. One question I had for you is, if you had to say what the #1 quality of a good, successful medical legal partnership is, what would that be if you had to say that this is the one quality, or a few if you want, that makes it strong?
I think it's the opportunity for those of us on the healthcare side to develop a relationship with, because there was and there continues to be uncertainty on the part of the healthcare providers, whether it's a nurse or a social worker or a nurse practitioner or a doctor, about, is this really a legal problem? You know, as I said at the start, our legal literacy is low. You know, we're not lawyers and nurses and social workers. And so being able to have Sarah's sympathetic and understanding teaching and support and sort of low barrier for asking questions. And because what would happen too is that I'd see a patient in clinic and the patient would leave. And then as I was writing my note or thinking more about the patient, I would think, oh, you know what? Oh, I didn't even think to ask that. Maybe this is thus and such. And so, you know, I could email Sarah or I text her or call her and sort things out after the patient has left. And that's helped too. So I think we've really become a learning institution because of the relationships that we have with Sarah. And I think that that's the most important feature of what we have. The relationships and the learning.
Yeah, that makes sense. And the communication, the line of communication, you know, like you said, so many times we go back, we look at our notes, and to be able to directly reach out to somebody who has the knowledge to get that answer so then you can continue processing what's important on your end.
Right.
That completely makes sense to me. Another question I had, and I don't know if folks, I'll check the chat as you're answering, is, you know, there's always work to be done, right? Things can always be better. Things can always evolve. Is there a future that you see for medical legal partnerships? And what does that future look like? How is it different? You know, where can we be versus where we are?
Well, I think the simple answer is to access funding and advocate for funding so that more medical legal partnerships can be established. And, you know, everything or in this country anyway, it seems always to come down to money. So if there's no money to pay the lawyer, you know, that the medical legal partnership is never going to happen. So one thing that we did as a result of our relationship is really work with the what's called VACO, VA Central Office, so VA in Washington, and engaged in advocacy and helped write regulations, draft regulations, so that the people advocating in Washington had what they needed to show Congress that this is what this is how it works, this is what it would look like. And so I think advocacy for funding, whether, you know, wherever that funding's coming from. And we really did the same thing with the city and county of San Francisco. There was a standard grant application that the medical legal partnership filled out, and we worked hard to really clearly explain what the benefits were going to be to the city and county, and advocated for that funding to be allocated to the medical legal partnership for seniors. So I'd say working to get more funding so that people can do this work, because people who hear about this say, oh, that makes sense. I think there's a lot of face validity to the concept, but going from, oh, I get it, and that sounds like a good thing to do, to actually doing it is the hard part. So you're up.
I'm muted, of course. Your answer kind of read my mind, because, you know, the next thing that I was thinking to ask, or that at least I was brainstorming, is, you know, what role do medical legal partnerships play in policy change? And it seems that their direct services are important, the policy change is important. And you already answered that basically, as long as the funding and trying, but is there any other way that you see medical legal partnerships being imperative in policy reform?
Well, yeah, I think just the advocacy piece, and we have so much credibility in doing the advocacy and writing the policy and talking to policymakers about why this is important and what the effects are. And it was super easy to make the case, well, I shouldn't say super easy, but to talk to the city and county of San Francisco, whose court systems were so overburdened with these petitions for guardianship. We found the pain point for them and were able to come to them with a solution. And then say, oh, by the way, we need money to help make it happen. But as is always the case when you're advocating and working with policymakers, what's the struggle that the system is having, and how is it that you can help alleviate or solve the struggle?
Awesome. Well, I do not see any other questions that came through. If I am missing any, I think we can give it a second and let folks pop them in or remind me. In the meantime, I know that you've already been speaking for long enough, but are there any last sentiments or any last thought that you would like to leave us with here today as we go forward in our fight for elder justice?
Well, we, and when I say we, I mean the legal half of the team and the medical half of the team would be delighted to be a resource or a contact. And if people have questions as they make their way through the afternoon and are thinking about what they can do or would like to do, we would really be delighted to serve as consultants, or even to email the question. However we can help and support, we really be delighted to do that.
Well, we do appreciate that. Thank you so much for being here, Dr. Fabiny. If anyone has any questions at a later date, you heard, you get to ask. And I know on behalf of the legal community and all of our folks here, we thank you so much for all the work that you do, for supporting, just justice and all the work you do with veterans and elder justice. And we thank you for carving out some time in your busy schedule, especially early in the morning for you, to be here with us today.
Oh, well, it was my pleasure. Thank you so much.